Hello again, everybody. This is Rusty, aka William, aka Dr. Robinson, and I am the Blues Doctor. And this is my podcast, The Blues Doctor Recommends. We're glad to be back after a week off. I was making house calls last week, and so much happened that we had to come back to discuss it again this week. So sit back, hit the like, hit the thumbs up, share, subscribe, make comments, all of those things, and here we go. So let's go on to the calendar this week. As of May 22nd, this was 1961, the song Mother in Law by Ernie Cato went to #1 in the U.S. charts. That was 1961. Ernie is a New Orleans native. He grew up here, was a singer, musician, guitarist here, and his big hit was Mother in Law. Ernie played that song until he died, which was 2001. He also opened what's called the Mother-in-Law Lounge on Claiborne Street and ran that till his death. When Ernie died, his wife Antoinette ran the bar until 2009 when she died. Then it was taken over by Kermit Ruffins, another local musician, of Kermit Ruffins and the Barbecue Swingers. Kermit renovated the lounge and it is still going to this day. Congratulations, Ernie Cato, on Mother-in-Law. Also on the calendar, May 23rd, 1970, this time, the Beatles' 12th and final studio album, Let It Be, started a 3-week run at #1 on the U.S. charts. Let It Be included the singles Get Back, The Long and Winding Road, Across the Universe, and, of course, the title track, Let It Be. This one was of interest to me because Let It Be was actually the first record I purchased with my own money. I got both the single and the album. I don't know what happened to the album, but I've still got the single. So this was of particular importance, and I wanted to include it here. And then in May 24th, 2023, Tina Turner, the energetic singer-dancer, died of cancer at age 83. She'd had a number of health problems in the last few years, including a stroke and kidney failure. Tina's songs included her time with Ike Turner as part of his review. Things like River Deep, Mountain High, What's Love Got to Do with It, many others made her a superstar. She had been dubbed the Queen of Rock and Roll. She rose to fame alongside Ike, who was her husband, in the 1960s with songs like Proud Mary and many others. Her kind of raunchy and energetic stage performance and her husky voice were recognized instantly. Tina won 8 Grammy Awards and was inducted into the Rock and Roll Hall of Fame with Ike in 1991 and again as a solo artist in 2021. Rest in peace, Tina. For our cancer segment this week, once again, I'd like to put aside our continuing discussion of the NCI's annual report on cancer because once again, we've had a current event that's kind of trumped that, and that is former President Biden's recent cancer diagnosis. Now, it's been all over the news. Lots of commentators have said lots of things about it to the point that it's pretty confusing. So what I'd like to do today is to discuss some of the facts that we do know, try to straighten out some of those inconsistencies in the various reports, and maybe let you know where some of the commentators are, if not lying, at least exaggerating or stretching the truth in order to fit their particular political affiliation. Here's what we currently know about President Biden's diagnosis. On May 19th, which was a Sunday, which is a little odd, his office announced a diagnosis of prostate cancer. President Biden was 82 years old. The cancer had a Gleason score of 9, and that's simply a way of evaluating the presumed severity or risk of recurrence or risk of progression of the tumor by looking at the slide under the microscope. There's a series of pathologic markers that you can look at under the microscope that will help you determine that. He was also said to have bony metastases, in other words, the cancer had spread to the bone. Turns out that President Biden had been complaining of urinary symptoms. That's all they said about it. They didn't say what. That could include things like delayed urination or urinary frequency or blood in the urine or painful urination or some combination of all those things. At any rate, he went to his primary care physician for that, and on exam, the physician found a nodule on his prostate. In other words, he had a rectal exam, and you can feel the prostate gland pretty well on rectal exam. It feels to be about the size of a walnut. It feels fairly firm. So if you feel a sharp outgrowth from it, you can be pretty sure there's something wrong there. So after that, the president underwent a biopsy, and that's done transrectally also. And it's not as bad as it seems. They actually give you some sedation for that, and the needle actually is very small. So you can get several cores or several passes, several pieces of the tissue to look at under the microscope via that biopsy. Also, he underwent a series of imaging studies, probably things like CT scans and our MRIs and our bone scans. Maybe that's the way they found he had bony metastases, and our PET or PET scans. Also, and this was interesting, the tumor was announced as being hormonally sensitive, and that's important. And I'll tell you why. That can be taken two different ways. First of which, and this is the most common way, the tumor may have had androgen receptors that were present on the original biopsy. In other words, when you looked at it under the microscope, you could actually see androgen receptors. Or really more realistically, a better way to phrase that is that when you stain the tissue of the biopsy with a particular material, it will show androgen receptors if they're there. Now, androgen is another word for hormone that particularly means the male hormones like testosterone. So if there are androgen receptors in the tumor, it's presumed to be androgen sensitive or hormonally sensitive, which means that the tumor should or may respond to treatment with hormones. Now, that's not the only way that could be interpreted, and this is where part of the problem has been. The other way to interpret it, and I've heard some commentators on the air cite this, is that he had been previously treated with hormone blocker therapy and it had a response to it. In other words, looking back, they could say he was hormone or that the tumor was hormonally sensitive because he had already been treated with a hormone blocker and the tumor had gotten smaller. Now, in general, that's not the way the great majority of oncologists would state that. In other words, the typical way for an oncologist to state that to a family and to a patient would be, oh, we've had androgen receptors identified on your biopsy, and the good news is that means it will likely be sensitive to hormonal therapy. The good news about that being that hormonal therapy is typically much less drastic than chemotherapy or surgery or whatever else you might want to do to it. And let me give you a little background on prostate cancer also. So prostate cancer is very common. It's the most common cancer in men. There are typically 300 some odd thousand cases in the United States every year, but there's only about 35,000 deaths every year. So what that tells you is the death rate for prostate cancer is much less than the incidence rate. What that implies is that most prostate cancers are relatively slow growing. In other words, most men who have prostate cancer will not die of prostate cancer. They'll probably die of something else before the prostate cancer gets them, because prostate cancer is a function of age. The older a man gets, the more likely he is to develop prostate cancer. In fact, if you look at autopsy studies in men 100 years old, virtually 100% of them will have a small prostate cancer coexistent, but they may not have even known about it. So prostate cancer is a difficult thing to diagnose because sometimes it grows so slow. Now, there is a fast-growing subset, and that's what Biden's cancer appears to be. As I said, it was assigned a Gleason score of 9 initially, which suggests that it would be of that rapidly growing or more aggressive subset. The fact that it had bony metastases that were identified also suggests that it's more aggressive. So that's what we know so far about President Biden's cancer. The treatment for prostate cancer can include a number of things, including surgery initially, and that's usually reserved for tumors that are confined to the prostate, typically in the form of radical prostatectomy. And that can be done minimally invasively or with the robot-assisted device now, and the morbidity for that is considerably less than it used to be. Other treatments include chemotherapy, and there are several of the traditional chemotherapy drugs that can be used for prostate cancer. Some patients with prostate cancer will receive radiation therapy, particularly for bony metastases. So President Biden might get radiation therapy for that. You can also receive hormone therapy, as I mentioned before, and there's several ways to administer hormone therapy. You can have so-called anti-androgens, in other words, drugs that actually physically block the attachment of testosterone, the male hormone, to the testosterone receptors in the tissue. You can have anti-androgen synthesis, and those include drugs that simply block the creation of testosterone at a different level. Or you could use what some people call gonadotropin releasing hormone blockers, which block the pituitary from producing, downstream at least, from producing testosterone also. So there's a variety of ways, and you might use more than one. In other words, a patient might be treated with some combination of those hormonal therapies. Finally, you can use orchiectomy, or removal of the testicles. And that has been done in the past. We do it relatively rarely now because those drugs work so good. And then there are the new molecular therapies, perhaps the most promising being the so-called immunotherapies. Drugs like Keytruda are among those treatments, and they are very promising for prostate cancer. And we're still currently trying to figure out what the best combination of all those treatments are. As I said, in general, if a lesion is confined to the prostate, you might consider radical prostatectomy. If it's metastatic or spread beyond the prostate, then you will likely consider some combination of all those other therapies. Occasionally, for men who are not good surgical candidates because they have other diseases going on, you might recommend radiation therapy as an alternative to radical prostatectomy. Really, though, the big question here, the one that most of the commentators have been talking about on both sides of the aisle, is this a brand new diagnosis? In other words, did he just have the diagnosis made last Friday? Or was the diagnosis made previously and he either did or did not get treatment for it, but they hid it from the public up until now? Now, I'm going to disagree probably with most of the conservative commentators here because it's clear to me, and I think to most other mainstream oncologists, that this could certainly be a brand new diagnosis. And I'll tell you why. The ways we diagnose prostate cancer are several. I mentioned earlier the fact that you can diagnose it based on a physical exam, and that's true. Another way we diagnose this is via screening, and the screening test that we use for prostate cancer is something called PSA, a prostate-specific antigen. Prostate-specific antigen is a marker that was found about pushing 30 years ago, identified to be associated with prostate cancer. However, PSA is neither all that specific or all that sensitive. In other words, if you draw PSA, it can both miss cancers that do exist, and it could say that there are cancers there that don't exist. That's the difference between specificity and sensitivity. In fact, it happens so much that there's a lot of extraneous data that will arise because of that, because if you have an elevated PSA, in other words, suggesting that you might have prostate cancer, then you have to do more testing. In other words, you might have to do a biopsy, or President Biden probably had more imaging studies or other things. You might even go all the way to some kind of treatment like surgery in the form of prostatectomy. On the other hand, if you do the PSA and it's negative or very low, and there really is a cancer there, obviously you have the potential to miss it for some period of time until it becomes clinically apparent. In other words, until you can feel it on exam or until the patient has some kind of symptoms from it. So PSA is not an ideal test. In fact, the U.S. Public Health Service Task Force in 2012 did not recommend PSA testing as a screening test for prostate cancer. Other medical organizations have recommended it, including the American Urological Association, which recommends PSA screening. I believe it's at age 50 for all populations, at age 40 or 45 for Black men who have a higher risk of prostate cancer, or for men who have a first generation or first degree family history of prostate cancer. So what do you do with that? Well, if you add up all the risks and benefits, statistically, you actually end up doing more harm than good by screening with PSA because of those low specificities that I mentioned before. In other words, if you have a high PSA, just out of the blue, with no symptoms, no findings on exam, no findings on imaging study, that means you've already not only spent a lot of money, but you've put the patient through a series of tests that they wouldn't otherwise have had. And there is at least some morbidity to all of those things. A biopsy could go wrong, or say an imaging study was wrong or mistaken in that it saw a mass that really wasn't there. And all of us in oncology have seen that happen many times. And you make the decision to go in and operate on the patient to remove the mass, and it ends up not being there. Then you've got the morbidity of an operation. And in fact, some of those people who get operated on for prostate cancer are actually going to die from complications of the procedure. Now, contrast that with the fact that, as I said before, prostate cancer is generally very slow growing. Prostate cancer may develop in a man in his 60s or 70s, but may never be the result of that man's death, because most men are going to die of something else before that very slow growing prostate cancer kills them. I can tell you I have a personal experience with that. My grandfather was diagnosed with prostate cancer at age 80. And this is kind of a funny story. His urologist recommended surgery in the form of radical prostatectomy to him at that age. He's actually in very good shape at age 80. But my grandfather declined it because he didn't want to go through that. And he did, so the surgery was not done. And about 2 years later, the surgeon, the urologist who recommended the surgery to him, fell over dead from a heart attack. So my grandfather outlived him. He actually lived on to age 101 and finally died of what we think was probably some combination of Alzheimer's disease and heart failure. So the prostate cancer never really had any significant impact on him. So that's the problem. Here's another way to look at the problem. In 1989, the incidence or the utilization of radical prostatectomy in the United States, in other words, the number of those operations that was done in the United States, was about 75 per 100,000 men in the country. Now that went up dramatically. By 1992, there were about 200 radical prostatectomies per 100,000 men in the United States. In other words, a more than doubling of the number of procedures done. And then by 2020, that incidence fell back down to about 100 per 100,000 men. But we know during that time, the incidence of prostate cancer was about the same over that 30-odd year period. So why did that happen? Why did the incidence of radical prostatectomy go so far up and then come so far back down? Well, I can tell you it's two things that happened during that same time. First of which is PSA. As I mentioned before, this marker was introduced to the public in about 1990. So what happened was we started finding men who had slightly elevated PSAs who were then diagnosed with prostate cancer, for which they were recommended radical prostatectomies that they had, but that didn't change the outcome. In other words, it didn't change the survival with prostate cancer at all. And then in 2012, the U.S. Preventative Task Force Service came out with their report showing that PSA was not a good screening test for prostate cancer, and the number of radical prostatectomies dropped. The number of prostate cancer cases didn't drop. It was the number of cases that were diagnosed based on PSA that dropped. So the urologists kind of had a field day in the early 90s when the number of cases went up dramatically. And they, as I said, they've slowly come back down and then kind of dropped through the floor in 2012 with the report from the U.S. Public Health Service Preventative Task Force. So what can we make of all this in President Biden's case? Well, without question, it is entirely possible that this truly is a brand new diagnosis. It was not made previously. It was not covered up, despite what some people may say. There are going to be several questions that are asked of the physician for President Biden and for some of the other people in his inner circle. One of which will be, did the doctor get a PSA test from President Biden in his most recent visit, which was in February of 2024? If he did that, then the next question, obviously, will be, what was that value? Was the PSA elevated or not? If the PSA is low, game over. That means this is a new diagnosis. There's no possible way that the physician could have diagnosed the prostate cancer prior to President Biden having symptoms. On the other hand, if it is elevated, then there will be other questions, such as, so what did you tell the president? What did the president want to do? And there's obviously all kinds of answers that could go along with that. Here's another possibility. What if President Biden refused the test? It is not an absolute. As I said before, the Preventative Task Force is not recommending the test routinely. Most primary care physicians are offering it and are willing to discuss it with their male patients. I can tell you, I declined taking the PSA test because it's not good. PSA is just not as good a screening test as is, say, mammography or the pap smear. It's simply not good, and it causes more problems than it helps. The other question will be, did President Biden ever have a PSA test in the past? And it has been said or been reported by the White House that he had one in 2014 that was said to be low or normal. So that gives you something to go by, but it doesn't say for sure whether his prostate cancer was just diagnosed or not. So those are the kind of questions that will be asked. I'm sure that there will be congressional committees that will try to investigate this, and they will probably subpoena the doctor and maybe other people to talk about this problem. But I would be willing to support a doctor who said, I offered President Biden the test, he declined it. Period. End of story. There would be nothing wrong with that. The doctor would have done nothing wrong. On the other hand, if he said, I offered President Biden the test, he took it, and the result was low, or the PSA was normal, end of story. There's nothing more to it. The only thing that could happen is if his PSA was elevated in February of 2024. Then they have to ask some more questions, and obviously the answers will be a little more tricky. But anyway, that's my feeling about this. I think many of the commentators on both the left and the right are overstating their cases. I think the right-wing commentators are using it for their political advantage by saying, oh, this must have been a cover-up. And I understand that, particularly in the wake of what was clearly a cover-up of President Biden's cognitive decline. There's no doubt in anybody's mind about that. It was apparent to all of us. All you had to do was look at him to see that. So in that context, I can see where you might jump to the conclusion that this was a cover-up also. But I don't think that's necessarily the case. At any rate, we'll find out in the next few days. Also, if you have any questions about this, I know this is a complex topic, and I've gone through it very quickly here and left out lots of details. I would certainly be willing to take comments on it, or if you want to contact me and talk about it, I'd be happy to do that also. So let's move on to something a little lighter. As those of you who have been listening know, I have been including a segment on high strangeness for the last few weeks. Particularly, we've talked about high strangeness in New Orleans, which is my second home, as I like to say, and there are lots of things that could be considered high strangeness in New Orleans. One of those I'd like to talk about today is the concept of the Mardi Gras Indians. If you've never been to New Orleans during Mardi Gras, you're probably not aware of this. The Mardi Gras Indians, or as they prefer to be called, the Black Masking Indians, go back over a century. In fact, maybe even as far as 2 centuries. The history of the Mardi Gras Indians is vague, and for many, many years, it was very secretive. In other words, they didn't like to share the story of the Indians with outsiders, particularly with white people. Basically, the Indians are groups or clubs of black men from various neighborhoods in New Orleans that get together on Mardi Gras Day for the purpose of having a party where they set up a little parade and they have colorful suits or outfits that they wear. And they create these suits themselves. They sew beads and shells, and I heard somebody say they used fish scales sometimes, feathers, and many other things to make very bright, very colorful costumes that they wear to parade down the street on Mardi Gras Day. And it's believed that this started maybe even before the Civil War as a response to not being allowed to participate in Mardi Gras at the time. Canal Street was segregated up till after 1900. In other words, black men could not come on Canal Street to watch the Mardi Gras parades at that point. So the black neighborhood groups got together to create an alternative to Mardi Gras for that day, and that became known as the Mardi Gras Indians. So that history goes back for many years. Another part of it is that the black Mardi Gras Indians or black masking Indians were among the people who couldn't afford to participate in a crew or a parade. Even when the parades became desegregated and black crews came up, like Zulu, which is a very fun crew and very fun parade, it still required a fair amount of money to participate. And unfortunately, to this day, many black residents of New Orleans don't have a lot of money. So as an alternative to that, they created the black or continued the black masking Indian tradition. The purpose of the Indians is to parade through the streets on Mardi Gras Day wearing your suits. And often they work on those suits almost all year long. Many of them put hundreds, if not thousands, of hours into developing these suits. The groups themselves have a very hierarchical organization structure. They have typically a chief, sometimes known as the big chief. They may have sub chiefs. They may have another category called the wild men. They'll have other categories called the spy boy and the flag boy. And all of those positions have specific duties in the hierarchy of the black masking Indians. But that's really what it started as, was solely as a way to celebrate Mardi Gras for people who couldn't participate in Mardi Gras in the more traditional ways. They, over time, developed their own rituals of dance, chants, songs. The lingo that they developed is almost unintelligible, at least to most of us today, and it was created in the past to be able to communicate with each other without the white man noticing. So you can hear lots of that lingo in common day language in New Orleans that was picked up from the Mardi Gras Indians. When the Indian groups march, or the tribes as they're called, march on Mardi Gras Day through their neighborhoods, they may encounter other Indian groups. And this is kind of fun too, because they will have sort of mock fights at this time. They will either encounter each other and ask each other to respect themselves. But what they're really doing is comparing their costumes to see who has the prettiest costume overall. It's a very highly elaborate, organized ritual that they go through for this, which is a lot of fun if you've ever seen it. Actually, that practice dates back to an earlier time when those groups, the tribes, did actually get in physical fights and people were hurt, sometimes seriously. There was a Mardi Gras chief named Tootie Montana who lived in the early part of the 20th century who took it as his duty to stop the violence between the Mardi Gras tribes and convert it into a competition for who had the prettiest suits. Chief Tootie Montana was very highly respected in the community for having done that. He actually marched for something over 50 years on Mardi Gras Day and was considered kind of the chief of all chiefs. I guess sort of like Don Corleone in The Godfather was the boss of all bosses. Well, Tootie Montana was the chief specifically of the group, the Yellow Pocahontas. His son is Daryl Montana, who I believe is still the chief of Yellow Pocahontas today. Another interesting Mardi Gras or Indian tidbit is that the Neville Brothers, the singing group from New Orleans, actually have participated in the Mardi Gras Indians groups also. They were with one of the tribes that originated in Uptown. The Neville Brothers actually grew up on Valence Street, and their tribe were the Wild Chapatoulas. The chief of the Wild Chapatoulas for many years was their Uncle Jolly. His name was George Landry. They referred to him as Uncle Jolly. And if you listen to Neville Brothers songs, you will frequently hear them referring to Uncle Jolly as they're singing. The only other traditional showing of the suits that the Indians wear is on what's called Super Sunday, which is the Sunday closest to St. Joseph's Day, or March 19th every year. The idea here is to let all of the Indians get together in a central place, and this is typically at a park in the central city area. It's kind of a central meeting place for the tribes from all over town. And they get together to show each other their costumes and have a good time for several hours on a Sunday afternoon. So that's the only other official time when the Indians bring out their suits and march around. There has been some controversy in recent years generated among the Indians themselves, particularly since Hurricane Katrina. In recent years, many times the Indians have been hired for special events to come out and perform. For example, restaurant openings will sometimes hire Indians. Festivals or conventions will hire Indians to perform. I've even seen some weddings that have had Mardi Gras Indians show up for the ceremony or the reception. And that's been criticized by some of the, particularly the older members who take it more seriously and believe it's more traditional, and that doing that or hiring out is selling out the culture. Mardi Gras Indians were seen and still are seen as something of a sign of defiance or a way of sticking it to the white establishment that wouldn't let them participate in Mardi Gras. So it's still, like I say, seen as something prideful, something to be proud of, a culture that they created that is unique to them, and selling it for money just to go participate in any event just seems distasteful. And I think I can understand that. And I would be remiss if I forgot to include one of my good friends, Big Chief Alfred Doucette, who is the chief of the Flaming Arrows tribe. Chief and I have known each other for a number of years, and he's a great guy. He's lots of fun, good entertainer. If you ever get a chance to see Chief Doucette in performance, don't miss it. As I mentioned before, the Mardi Gras Indians have created a number of songs that are particular to Mardi Gras that include some of this patois or lingo that they include in their chants. A number of those songs are popular in New Orleans. Most of them haven't gotten much popularity outside of town, but one you may have heard of that has, and that's Iko Iko. The Dixie Cups had a hit with Iko Iko in the mid 1960s. Dr. John did another version of Iko Iko in 1972 that became a hit also, and there have been many other covers of that song to this day. In fact, many bands in the New Orleans area regularly perform Iko Iko in bars and music clubs and so forth, and it happens all the time. In fact, I'm going to show you a clip of a performance of Iko Iko very recently at a place I've been involved with. This is Dwight Breland and Tony D'Alessandro's band with their performance of Iko Iko. Probably tell this song is fairly complex. The rhythm is very complex. The lingo or the lyrics include influences from Africa, from Haiti, from Native Americans, and obviously some from Europeans as well. So these songs are lots of fun. They're really a history story in and of themselves. I would strongly encourage any of you who are more interested to look up the Mardi Gras Indians and their music and everything else about them online. There's lots of videos in YouTube. There's lots of books about them, and it's just fascinating. And I've only been able to give you just the barest hint of it here today. And that's about all I had this week. I would like to introduce some new friends this week, and that is the Woodwalkers Bigfoot Research Team. The Woodwalkers are a group of individuals who are interested in the topic of Bigfoot, and they were created and founded and still led by Spencer Jameson, Misty Haynes, and Greg Howes, all of whom are friends of mine. The group is large in the sense that there are probably between 50 and 100 people who are regular watchers of Woodwalkers. They have weekly podcasts, sometimes more than weekly, and occasional actual field hunts for Bigfoot in a variety of areas across the United States. So if you're interested in the topic, even just learning about it, maybe you're not interested in going out in the field looking for it, but if you'd just like to see what this phenomenon is all about, check out Woodwalkers. They are very inviting, very friendly, never turn anybody away, and you can learn a lot about what is going on in the Bigfoot community. Finally, as I say each week, please watch next week's podcast, okay? See you later.